Welcome to our 126th TMIT National Research Testbed webinar. The title for today's webinar is a dual title of Drug Diversion Scenarios and an Update on Patient Suicide with two great leaders. I am Chuck Denham. I am the chairman of TMIT, and I'll be the MC for today's program. I'm on the third slide, which is our slide to remind you to turn your WebEx volume up to the maximum, your computer volume up to maximum, and if you're using external speakers, up to the maximum. If you are not getting adequate audio, then please click on the participants window and then click on request phone icon, and those of you that have the slides, that's on slide 4, and then you can get a better audio. On slide 5 is the landing page for safetyleaders.org, www.safetyleaders.org. For those that want to come back and collect further resources or watch the program again, click on upcoming events or the webinars and meetings tab, and that will take you to today's webinar, and you'll land on this page that has Dr. Kim New and Assistant Chief Vicki King from MD Anderson, and you'll see their pictures there, and we'll post additional resources to this web page on slide 6. Slide 7, and those of you that do not have the slides or want to go back and collect the slides, that's where you'll be able to download them. We just want to mention our social media addresses, and here in 2019, we'll make them much more active than they have been in the past. On slide 8 is our purpose statement, and our purpose is we will measure our success by how we protect and enrich the lives of families, patients, and caregivers. And I really believe today's dual topic program covers both patients and caregivers with some very challenging areas of focus. Our mission is to accelerate the performance solutions that save lives, save money, and create value in the communities we serve and the ventures we undertake. Our disclosure statement is on slide 9. There are no pharmaceutical or device products or services that will be addressed today, and the full disclosures of each of our speakers are on this page. Our speakers and reactors include Dr. Kimberly New, who is a RN, but also has her doctorate in law jurisprudence, and we thank her for speaking today on drug diversion. We have Assistant Chief Vicki King from MD Anderson and the University of Texas Health Science Center, and our National Patient Advocate and Voice of the Patient, Dan Ford, who will be part of our reactor team, as well as Dan will also be our Voice of the Patient now. And Dan has developed a deep passion for patient safety and medical errors after experiencing that in his family. He is both a national author, having helped write a number of articles with us in patient safety, as well as contributed to the National Quality Forum Safe Practices reports and components for the safe practices. He served on multiple committees. He served as a PFAC member at major medical centers. Dan, would you please open us and set our compass heading with the Voice of the Patient?
I will, Chuck. Thank you very much. And I would like to welcome all of those in the online audience, as well as to our faculty. And I want to thank you, Chuck, for these webinars, which you have been doing for over 10 years. The topics are always leading edge and timely. Today's topics are very, very critical, and in my opinion, require all hands on deck to identify and to resolve the issues. My family suffered a medical error tragedy some years ago. At the heart of it was a morphine overdose, and thus my interest in particularly the first subject today. We talked briefly before with the faculty members, and I'm very, very impressed with the experience and skills that these ladies will bring to the table. Back to you, Chuck.
Great, thank you so much, Dan. And as we were talking in the speaker's green room, virtual green room, Dan has been a tireless champion of inviting patients and families into root cause analyses, and so thank you for that as well, Dan. So I'm going to rapidly go through an update of what's in the news, and then our webinar recap from April. Yesterday, an article came out in USA Today addressing the Leapfrog Group reports, and those hospitals, and a report also from the Armstrong Institute at Johns Hopkins regarding an analysis of these numbers. And this is close to my heart because I helped launch Leapfrog's survey. Our team wrote the survey and worked with a leadership team, including Don Berwick and a number of other leaders, to set up the 1,000-point scoring system, and then had the honor of disseminating it and helping, I think it was about 1,260 hospitals initially in the Leapfrog program, which I think has really helped the national patient safety community, as led by a number of employers, including General Motors, and a lot of the leaders of that group have retired. If you would like to download the Armstrong Institute report, you could see it here and get a lot more detail. So again, we won't be covering the report. We just want to let you know that this is something that you probably should download and get a handle on, and see what is being said. Today's topic, our first topic, is on drug diversion, and the reports in the press are stating that we really have a tip of the iceberg. And there'll be another document just before we introduce Kim New that has much more detail on these 47 million doses of legally prescribed opioids that are stolen and diverted. Also in the news are these continued reports on what's happening in big pharma, as well as this prescriber bust that occurred. So we know the DEA and the Department of Justice are really focusing on this, and we're seeing lots of oscillation of various things in the marketplace. So keep your eye on that as it develops. The other information that we thought really important, and especially on the tails of Dr. Gladstone McDowell's talk last month, was the critical issue of cocaine deaths and stimulants, and mixing stimulants, and deaths without any opioids. So we're also seeing a pattern of a change in what we're seeing in deaths. So we have to really keep our eye on this as we think about those that are in opioid overdose situations or drug overdoses. So it's really important to realize that the abuse of these drugs is evolving, and we'll ask Kim to address those. Also, we're now seeing that the drug distributors are getting caught, and this is the slide on slide 18 addresses the first criminal charges for drug distribution, and so real accountability is being addressed. Also, sadly, in the last month, because we're focusing on our bystander care patient safety program with active shooter events, the deadly shooting at the California synagogue, and how critically important it is that we are training bystanders, including the security guards and the volunteer health ministry folks at houses of worship and faith-based organizations. So we're announcing this month, actually, we're launching a health security certification course, and we'll be teaching the first course at a church here in Orange County. We have over 70 leaders. It's a train-the-trainer program. Dr. Boats from MD Anderson is coming to help teach it with us. It also is addressing sudden cardiac arrest, and here's another article of more regarding sudden cardiac arrest. As we know, there are more than 356,000 such out-of-hospital cardiac arrests per year. We're not covered very well by people that know how to do CPR or AEDs, and that's why this is such a critical topic. Also, the Stop the Bleed kits at Cal State, you'll see more and more activity, and I think a lot of hospitals have not taken the advantage of the grant support and being able to start Stop the Bleed programs with their trauma teams and ED teams. So we'd really highly encourage you all to look at the American College of Surgeons bleedingcontrol.org and join if you can. There are again, another shooting, and these are in schools. So the group actually that we're training this Saturday include the University of California Irvine EMT teams. So if you're wanting to start a program in your community, look at the college students that are in pre-med. Many of them have EMT training and are dying to be more involved in healthcare. It's a wonderful opportunity to connect with those in the local colleges. Also, we've been following for some time, and we may have Vicki King comment on workplace violence, because that's another topic that she has really been a wonderful contributor to us in the past couple of years. So there are more and more of these concerns going on. Also, even Anderson has been experiencing concerns of the nation-state espionage that's going on, and where many, are over 130 medical centers, academic medical centers, are all under attack regarding the theft of information and conflict of interest. Just reminding you, the August 2018 last year, the letter that went out to all of the medical centers regarding disclosure of and conflict of interest, both with national companies and pharma and device companies, but also nation state, and this has led to a number of these issues. We're also following a number of cases for you, including the Johns Hopkins case where all of their hospitals have been subject to patient safety issues. The writers that have been following it and have written now almost 30 articles regarding the Johns Hopkins All Children's Hospital, as well as the other hospitals in the Johns Hopkins system, were finalists, ended up being finalists for a Pulitzer Prize, and they continue to be reporting on it. So a number of cases that we're following for you, and in the resources section of this slide deck that we won't cover today are the Hopkins, Memorial Sloan Kettering, the Baylor St. Luke's, Brigham and Women's, Vanderbilt University, Duke University, and the University of Maryland Medical Center. There are a number of stories that are still coming out. We are assembling case studies of each one of these in order to develop a continuing medical education, continuing nursing education, and risk management unit course regarding conflicts of interest. So there are more slides in the resources section, which we've started 2 months ago. We started a resources section to put more slides in your deck. So you have many slides that we won't cover today, and you'll see the reduced images like these that just tell you that we're covering them. So I'm going to shift gears now. We're at 11 minutes after the hour, right on time. Quick summary of the survey results of the 5 rights of pain management that were covered last month by Dr. Gladstone McDowell, probably one of the leading pain management folks in the world, certified in 4 specialties. He's a urologic oncologist, urologist, general surgeon, anesthesia, and pain management. And we ask, would you like more on pain management safety issues? And it's rare that we get 56% of you saying it, giving us a 10, another 16% 9. So we will in the next 6 months be covering more pain management issues. And Kim, you may want to comment on those. I'm not going to go through the topics on slide 33, but please review them. These are the topics that you want more information on that include staff nurse roles in page management, opioids in the hospital and prescribing, delirium, a whole number of topics here that we'll make sure to cover for you in future webinars. Our second topic last month was led by Dr. Greg Boats, who is a full professor of critical care at MD Anderson, as well as on staff at on faculty at Stanford University, and Chief Bill Adcox, who is the Chief of Police and the Chief Security Officer at MD Anderson. And in the resources section, you can see more of the slides, but they covered the fatal wounding patterns and bystander care and patient safety issues in pre-hospital care with active shooter events. And so there are a number of papers that are now coming out that are autopsy results on the wound patterns and why we need bystander care. So the MedTech program, which we co-founded with them, addresses the 7 areas of what we call hazard areas that bystanders can have a huge impact on with bystander care in the first 10 minutes before EMS arrives. Wanted to remind you that those of you that haven't seen our webinars, there are YouTube safety briefings on YouTube, and the links are on slide 37. And we've been very careful about not telling the bad guys too much detail, because it turns out that all of these active shooter events, the FBI has told us that they are studying the web for up to 100 hours each, and studying, and over 50% of the active shooters mention Columbine. So we're very careful about not giving them too much detail so they can't hurt as many kids. The article regarding the MedTech program is in the November-December issue of Campus Safety Magazine. We were asked then to comment on and supplement to the New England Journal of Medicine article on active shooter events in healthcare facilities, which we did, and then that was published in the January-February issue. And upcoming in the June issue is how to use what we've learned in patient safety to start rapid response teams in churches, colleges, schools, and businesses, and take the lessons we've learned in rapid response teams and how we could convert some of that knowledge or use some of that knowledge translationally to put together volunteer rapid response teams in organizations. We ask the audience, do you want more on bystander care issues? And you can see a little bit more of a bell curve. 26% gave us a 10. So we're going to provide more information and possibly standalone webinars starting in July so that we don't complicate the rest of our webinar series. If we see super high yeses, then we put them in our core curriculum. But we'll be having a second webinar starting probably in July on bystander care. The topics that we covered were on slide 42, and also this issue of violence and workplace violence has popped up in the news as well. We wanted to add that with this Nevada Current report, and also the Healthcare Innocence Project, which is a focus on those that have been improperly maligned and handled. We asked the question in our survey last month, would you like more on workplace bullying and violence issues? And Vicki, take note, this is definitely an endorsement of wanting to have more on workplace violence and bullying, and we'll ask you to speak to us again. Page 46 or slide 46 covers the topics that you may have a pretty large response in terms of the topics that you'd like to have covered. So that leads us to introduce, and we're right on time. We're at 60 minutes after the hour. We had such a successful response from our webinar series that we offered with David Marks on just culture, and especially when we covered case studies. So in my conversations with Kim New, I said, Kim, every time you speak, people want more on drug diversion. How about instead of covering it in a topical area, we tackle case studies? So what we did was we did the same thing for today's webinar that we did with David Marks. And you can go, by the way, if you see the link below, if you want to go and watch the Just Culture high impact case studies, watch it. We got rave reviews from it. We're going to have David back, but since this idea of case studies was so well received, we decided to do that with Kim. Also, what we wanted to do was address a couple other things that are in the literature. There's a great report, and Kim may add a little bit to this, regarding the report from the Proterra that reports the 47 million doses lost due to healthcare employee misuse. And you can see just a sampling of some of the graphics in this great report. And Kim, maybe we'll ask you to comment on those. Also wanted to remind you, now that we're going to introduce Kim, to go back to look at the series. We provided the 3 links of the prior presentations that she's given. Kim is an RN and a JD. She is a specialist in controlled substance security and DE regulatory compliance. She consults with many healthcare organizations, made a career of assisting facilities, very practical, has really given us some great insights on the topic. She's co-founder and executive director of the International Health Facility Diversion Association, and she is on the executive board of the Partnership for Safe Medicines. And so it's really a great pleasure to have Kim now address a drill-down approach using the case studies that she came up with for us. Kim?
Thanks so much, Chuck. We'll dive right into it. So as Chuck mentioned, we're going to look at some actual case scenarios, things that we can review and actually take some takeaways from. So the first one is a personal stressor. This is a very common scenario when we're investigating drug diversion. As an independent investigator, I'm not aware of the personal details of the individuals that I'm investigating, but once I have a chance to interview these individuals, I oftentimes hear that they have some type of personal stressor going on that has led them down this path of drug diversion. So a few cases to consider. One is the SICU nurse with back pain. This was a young man who was in his 20s who had chronic back pain. A relatively new nurse who was very reluctant to take anything very strong while at work because he took his job responsibilities very seriously and he didn't want anything that might impair his judgment. Unfortunately, one night he was having severe pain and he had some morphine waste that was left over from a dose he'd given to a patient. He decided to self-inject, and the relief he got from the morphine was astounding, according to him. He swore he would never do this again, but as he later admitted, it was a very slippery slope. Every time he started to feel pain, he would go ahead and divert some morphine, not always waste, sometimes actual doses, and inject himself. The way he was detected was that he was an extreme outlier in his morphine use. He didn't realize how often he was doing this. When I met with him about 6 weeks after he started diverting, he said he thought he had maybe diverted under 10 doses. In fact, it was in the hundreds. We also had a case of an individual who she had gone through a divorce. She worked the day shift, and she found herself in a situation where she was taking care of children by herself. She was no longer co-parenting. She was on her own, and she was quite overwhelmed with her job responsibilities as well as her responsibilities as a parent. She went to some physicians, got a prescription for a sleeping pill, Zolpidem, and that helped for a while, but she quickly realized that she needed more. And particularly with the increasing stress in her life, she decided to start stealing Zolpidem while at work. When she was ultimately caught, what she said is, I have a prescription, but my physician won't give me any more, and I absolutely have to have this medication in order to be able to meet all the demands in my life. I have to get a good night's sleep, or I can't come to work and do what I need to do here, and I can't take care of my children. So she was in a very stressful situation and had turned to diversion of sleeping pills. Of course, she was caught because she worked the day shift and was pulling large numbers of sleeping pills, which is quite a red flag. And then we had a case in which there was a nurse who was a former nurse Rookie of the Year. She put a lot of pressure on herself. She was on a number of different committees, was very active in her work activities, and was also in advanced practice nurse school. So she was getting her master's degree. In addition, she was 9 months pregnant, and she was caught as an outlier in her use of oxycodone. And what she was basically doing is, she said she had a lot of back pain associated with her pregnancy, but she also was having a lot of difficulty coping with all of the demands in her life. She was working full-time in school, ready to have her first child, and she was diverting large doses of oxycodone, which she was consuming throughout her pregnancy. So some of the things that you can possibly take away from these types of cases. One is it's important to discuss the risks of diversion and make staff aware that we're all vulnerable. We don't want to keep this underground. We want to be able to talk about it openly so that there isn't so much stigma associated with this, and so that people may feel more comfortable speaking up if they have a concern. Ensure that staff know what the resources are that are available to them, EAP and other resources. Train nursing supervisors, so charge nurses and others who are immediately supervising staff, to recognize the signs of overwhelming stress and to communicate with leadership openly about those, and encourage staff to report when they are concerned that a colleague is struggling. They need to look at that in terms of supporting their colleague, not doing something to undermine them. Another scenario we see commonly is the anesthesia dual source. So this is a situation where we have multiple different places for anesthesia to pull their controlled medications, and this is not that uncommon. If you look inside at your facility and you ask, where can anesthesia pull controlled drugs, you'll probably find that there are a number of different locations they can go to, and sometimes very different types of dispensing. So in the first one, we had a situation where there was variable practices by anesthesia. In this particular scenario, there was an ADC, or an automated dispensing cabinet, in labor and delivery. The anesthesia providers had access to that, but about 50-50, half of them would ask the nursing staff to pull fentanyl for them, and half would get their own. And when you have this type of variability, there's no red flag when an anesthesia provider asks a clinical staff member to pull anesthesia, and that's exactly what was happening in this particular case. The anesthesiologist was going to the automated dispensing cabinet, pulling a dose for a patient, but then going to the clinical staff and asking a nurse to go get fentanyl for that particular patient as well. So we had dual sources, and ultimately this was brought to the attention of the facility because the nursing staff started to feel uncomfortable about what was going on. They had seen this provider going into the medication room, and the provider had increased the number of times he was asking staff to pull fentanyl for him. So they made a complaint, and a further investigation ensued. Another case involving a CRNA who was pulling fentanyl from the PACU as well as from the anesthesia automated dispensing cabinet. So this was a facility that had anesthesia cabinets in every OR, and typically that should provide all of what the anesthesia provider needs at his or her fingertips. But in this particular scenario, this CRNA would pull a fentanyl right before she left the OR, and her rationale was, well, I may need to give the patient something en route to the PACU. But then when she arrived in the PACU, she would tell the PACU staff that the patient was having pain. Could they pull a fentanyl for her so that she could administer that, and that she would document it. And what was ultimately happening is she was diverting the fentanyl. It wasn't necessarily going to any patients, and she became an outlier in that particular case. And then we had an anesthesia provider who used kits. So these are, the little packs that get dispensed out of the OR pharmacy, and they had kits as well as anesthesia ADC. So they had these special anesthesia automated dispensing cabinets in most ORs, or in all of their ORs, quite frankly, but they didn't have them in procedural areas. And they had some kits for the purpose of anesthesia traveling to some of these procedural areas where there wasn't an anesthesia automated dispensing cabinet. But what this particular provider was doing is he would pull the drugs that he needed from the anesthesia ADC, and then he would also go and get a kit. So he had, again, dual sources and was able to divert substantial amounts of fentanyl. So one way this can be avoided is to eliminate multiple sources if at all possible. And the other big thing here is having consistency, standardization in anesthesia workflows and how they're handling controlled substances. Most of the cases that we see in the recent past have been cases that were facilitated because there was no standardization. And so when someone asked a nurse to pull something for them, did not raise a red flag. Require a two-person verification anytime controlled drugs are handed off to anesthesia. If an anesthesia provider requires or requests that a nurse pull something for him or her, make sure that there's actually a verification that was handed off in the EHR. And there are spots in the anesthesia records for most EHRs to be able to document that. Monitor all sources for duplicate withdrawals, and that means that you want to look at not just the transactions by the ADCs in the OR, but actually look across the facility and see what's happening with any particular provider. And audit at least, now this is a very much of a minimum, 10% of all anesthesia cases across the facility, but remember, it's not just the operating rooms. So that has to include other places where anesthesia goes, such as endoscopy, interventional radiology, EP lab, cath lab, and MRI, and other areas within the facility. So you want to make sure you don't limit your anesthesia auditing to just the OR. Another diversion scheme involves excessive authority in the pharmacy, and this is another very common scenario. If you ask in your pharmacy kind of who runs the show in terms of the controlled substances, you'll oftentimes hear that there is a pharmacist or a pharmacy technician who is the ADC administrator, and they handle controlled substances at the vault. And oftentimes they have a lot of authority when it comes to controlled substances, and a lot of times it's unchecked. So in this first case, there was an individual who was working at the pharmacy. She was the ADC administrator, so she handled giving users their access to the automated dispensing cabinets. She would discontinue their access. She would reset their passwords when they needed that done. But she also had the ability to go into the controlled substance vault. That was really her area that she physically handled during the day. And what they had done at this facility was they had required that there be a witness for certain procedures to try to make sure that diversion didn't occur. One of those procedures was removing controlled substances, significant numbers of controlled substances from the vault at any given time, or destocking it out of the vault. And what she ended up doing is she adjusted the stock out of the vault, hundreds and hundreds of pills of hydrocodone, and she had to have a witness. So she went and created a duplicate identity. She created a user who was a fictitious user and used that person's identity to witness herself as she pulled hundreds of pills from the vault. And she got away with it for a fairly significant period of time. And then there was a pharmacy technician in charge of diversion auditing. So he was doing all of the auditing for the facility, looking to see if there were any signs of diversion. But in addition, he was very, very helpful, and he would go and help staff by troubleshooting problems with the automated dispensing cabinets in the clinical areas. And he developed a scheme where he could go from cabinet to cabinet to troubleshoot or to fix something that he said was wrong with the cabinet, and he would pull small amounts from cabinets all across the facility doing this troubleshooting, and so he never really flagged on the dispensing cabinet reports or the outlier reports, because he was diluting the data by going all across the facility. But it didn't really matter too much because he was looking at the data, so he was auditing himself, and of course gave himself a passing grade every time he looked at an anesthesia or at a diversion report. Another way that facilities can help avoid this type of activity, one is to strictly limit who has ability to create user profiles, and always have an independent audit of all users on a weekly or monthly basis. So if whoever is in charge of giving access to automated dispensing cabinets, to the automated vault, that person should not be doing auditing of how that's done. There should be someone who is independent, who's looking to see who all the new users are each week or each month, and then verifying that those are actually legitimate users. Ensure that pharmacy staff transactions are audited as part of ongoing diversion auditing. The situation where the pharmacy technician was taking large amounts of hydrocodone out of the vault was one that would have been detected, but the focus at that facility was on nursing staff. Nobody was really looking at the pharmacy, and so no one looked at the transactions out of the vault unless there was a frank discrepancy, unless there was, a flag that something was missing. And since this individual was witnessing herself, there was no discrepancy. So it's important to include pharmacy in your auditing and eliminate ADC access for diversion auditors. That is something that is important. If there's an individual who is auditing, it's really a conflict of interest for them to be able to access the automated dispensing cabinets. The next scenario was the opioid switch. Now, this is very common. We've seen a number of cases in the past year in which individuals were switching out medications. And so the first case was in the ER. There was a nurse who would waste a lot of oxycodone. She didn't really waste anything else, but there was always some reason for her to be wasting oxycodone. She would say that she dropped the pills. She would say that the patient refused it, that the patient spit it out or vomited it. So there were a number of different reasons why she had to continuously waste oxycodone. But a closer look revealed that she was pulling oxycodone and pulling acetaminophen for the patients simultaneously. So when she pulled hydrocodone, she never pulled acetaminophen. But when she went into oxycodone, she would pull oxycodone and acetaminophen. So there were these paired transactions. And what we ultimately found, and what she ultimately confessed to, is that she was giving the patients acetaminophen and that she was keeping the oxycodone for herself. So that she was wasting acetaminophen and keeping the oxycodone for herself. So her peers would see her throw a white tablet into the waste container, and they would just make an assumption that that was what she claimed it was, and in fact, that was not at all what was happening. She was wasting acetaminophen. We had another case that involved a PACU nurse, and she did the same type of thing. She would actually go and cancel a transaction for acetaminophen. So in the automated dispensing cabinet, what that means is I can go in and plug in someone's name and that I'm going to get acetaminophen for them, and the drawer will open, the pocket will open, and then I have access to whatever is in that pocket, in this case, acetaminophen. If I cancel the transaction, then no transaction is recorded, but I've still had access, so I can still pull acetaminophen out of that pocket without being detected. And so what she was doing is she would cancel transactions for acetaminophen for these patients and at the same time pull oxycodone. And this is the scenario where she was actually giving the patients acetaminophen and keeping the oxycodone for herself. So how do you detect this type of situation or prevent it? Train staff to actually visualize waste they are witnessing. They actually have to take a look and not just shrug it off as one of the routine things they have to do throughout the day that isn't that important. It's really important to see what's being wasted. Monitor your transactions at your automated dispensing cabinets, looking for suspicious transaction pairs. Anytime you have two drugs that are pulled simultaneously, one's an opioid and another one is something that could be a substitute, it's really important to pay attention to that and dig further. And discourage wasting of complete doses and monitor for that. Unfortunately, I've recently seen several scenarios where facilities didn't have a return bin for nursing staff to return unused controlled substances. And in many cases, these facilities had put a policy in place in which clinical staff were required to waste complete doses if they pulled something and didn't use it because there was no mechanism to return the item. And that's a dangerous setup because wasting of complete doses is a very common method of diversion. Usually they're wasting a substitute. So it's important to make sure that you don't encourage wasting of complete doses. There was another scenario in which this happened in the ED, but it could happen in any unit. It happens a lot in units where there's a fast turnover, where there may be outpatient procedures and patients come and go quickly. In this particular scenario, however, the facility had a policy or a setting in which patients' profiles stayed active in the automated dispensing cabinet system for 24 hours after they were discharged. So if I was a patient and I was discharged at 8 p.m. on Tuesday, my profile would still be active in the automated dispensing cabinet. You could still pull medication under my name all the way until 24 hours later. And this nurse was very savvy, realized that this was the case, and so she would come in and input orders into CPOE for hydromorphone, which was her drug of choice, and she would always do this on patients that had been discharged. Some had been discharged, 16 hours earlier. And oftentimes she would input the orders under the name of a physician who really had no role in the care of that patient. It was one that was there presently when she was inputting these false orders. She did this over an entire year, and she was ultimately found to be diverting because she was so impaired. She was diverting so much hydromorphone. And when we went and looked at what had happened over the course of the previous year, one of the things that I found interesting is that 100% of these orders were verified by the medical staff, or nobody disputed these orders. They were just simply checking the boxes and confirming that these were legitimate orders when in fact all of these patients had been discharged previously. So what are some of the things you can do to help prevent this type of activity? Limit what we call the patient keep time, or the length of the patient's active profile from the time they're discharged. Best practice is no longer than 2 hours. Now, if you're a facility that has a 36-hour keep time, please don't quickly put that down to 2 hours because you'll probably have quite a rebellion on your hands. But I recommend that you incrementally decrease that patient keep time with the goal of getting down to the 2 hours or less. We have some facilities we work with that are actually able to have an hour or even 30 minutes. And educate medical staff to verify the details of orders that are input by nursing staff. Don't just auto-verify things. Don't just simply click things off as legitimate without actually paying attention to the details. And then we have a scenario involving prescription fraud. And this is important because there's been some fairly large settlements with the DEA over this type of situation. So in this particular case, there was a medical assistant who worked in this physician practice. And in this case, the medical assistant was somebody that was very heavily relied on. And we see that very commonly in physician office practices. The medical assistant really helps the mid-level or MD providers and is always there to take care of some of the fine details that have to be attended to while the provider focuses more on the patient evaluation and plan for care. So in this particular scenario, there was a medical assistant who was asked to commonly asked to fill out prescriptions for opioids. So she would fill all the details in, and then the provider would sign off on these prescriptions. And she had access, of course, to the provider's DEA registration number. She would also call in refills for C3s through 5. So she would be calling those into the retail pharmacies on a fairly regular basis, and she had access to a very large number of patient identities in their electronic system. So she was able to pick all sorts of different patients to call prescriptions in for. In this situation, what she was doing is forging prescriptions, calling in false prescriptions in very large quantities. And some of the local pharmacies started to get suspicious. So their first step, and this is very common, is they would call the office. And of course, the call would be routed to the medical assistant for the physician. That's the standard practice. And so when the medical assistant would receive the call from the pharmacy, she would say, oh, yes, that's a legitimate prescription. Of course she would say that. And so she was able to continue this diversion scheme unchecked for a substantial period of time. There are ways that you can help avoid this, and there are ways that you can detect it if it is possibly happening. First of all, of course, it isn't a good practice to have medical assistants completing controlled substance prescriptions prior to the provider signing them. That's just not a good practice to begin with. But it's also important to conduct an independent audit, at least monthly, of prescribed controlled substances, comparing them to the Prescription Drug Monitoring Program database. So look to see in the PDMP what that physician has prescribed and match that up with the patient records. And this is oftentimes done by the office manager, but it should be done by an independent individual, not the medical assistant. So it's important to do that. That'll help you identify fraudulent prescriptions pretty reliably. Route pharmacy concerns. When they call, route their inquiries to an independent staff member, if at all possible, not to the medical assistant. The independent staff member can pull the chart and verify details. If that's not possible, then ensure that there's at least a written record of all such calls and that those go to the office manager, an independent individual in the practice who can verify those details. And then have physicians and mid-level providers check their own profiles in the prescription monitoring database periodically to make sure that they don't see prescriptions that they, in fact, did not generate. The last scenario we're going to talk about is when waste is falsified. It's a very common scenario across the country. Individuals are able to divert from waste in just about every facility that I work with, just because staff really don't take wasting responsibilities that seriously. It's one of the things that they just cut corners on. So the first case scenario was a close-knit unit where waste was never actually visualized by the witness. In fact, when this nurse was caught diverting, she said that she had been diverting for over 2 years, and she had diverted every waste that she had, and no one had ever asked to actually see it. So she said she could pocket it every time. In interviewing staff in this case, I talked with some of the newer nurses, and one of the nurses actually told me that she had been bullied by her peers because she had worked at a facility that insisted that you visually witness waste. And so when she came to work on this unit, somebody approached her and said, "Will you watch me waste?" And they were kind of secretive about it. And she said, "No, I can't sign off. I have to actually see it." And her peers really criticized her and called her out because they accused her of not, trusting her colleagues, of being difficult and belligerent. And then we had another case in which there was a traveler husband and wife team who witnessed each other wasting large volume PCA, so patient-controlled analgesia syringes, and other opioid infusions. They worked in a critical care area. It was an unusual situation in that they were both assigned to the same unit on the same shift, and there was no prohibition to them witnessing each other. So in this particular scenario, they witnessed each other multiple times, and of course, a lot of the wasting that was done was not really wasted. It was diverted waste. So waste is a common source for diversion. Staff oftentimes do trust each other. They just need to understand really what is involved in wasting, and they need to be educated about their wasting responsibilities. So make it clear to staff that signing as a witness is very similar to making an entry in a medical record. It needs to be taken seriously. Review waste buddy reports. Many of the automated dispensing cabinet systems do generate waste buddy reports, or reports that show where two people commonly waste together. Although collusion, like the traveler couple, isn't common, what those reports can oftentimes show you is that there is a weak witness that's being preyed upon by some of the nurses. So that person ends up being a waste buddy, commonly for a particular nurse. Include waste in ongoing diversion auditing, and never allow, it goes without saying, related individuals to serve as a witness for each other. So some of the takeaways very quickly: diversion is an ongoing risk to patients, to staff, to facilities, and the community. It's important to understand that these people are very clever. They're oftentimes one step ahead of us. But if there is a lack of auditing, or if there is a situation where there are loopholes, these individuals will find them. And so it's really important to tighten our practices, make sure that we have standardization. And then the other thing I think that's really important is to always have, following each of these cases, a post-case review. Make sure that you pay attention to some of the lessons that you can get out of these types of cases. How can you change things to make this less likely going forward? What's working well, what's not working so well? And I can assure you, in every single diversion case that I have ever investigated, there are lessons to be learned. So be sure and implement that post-case review. And now I'll turn it over to you, Chuck.
Well, thank you very much. What a wonderful job. Really well done. And I know we'll have some good dialogue after we finish our next session. So thank you very much, Kim. Really, these practical case studies I think are so helpful. So as a brief introduction to Vicki King's presentation, here's a recent article regarding patient suicide. And we know this happens a whole lot more frequently than we would wish. I know during my residency in radiation oncology, we had a number that occurred over the 5 years that I was at MD Anderson and Texas Children's and Methodist Hospital, a number that happened at the VA. So it's a real pleasure to introduce Vicki King, who has spoken before and really covered a number of really great topics. She's the Assistant Chief of Police with the University of Texas Police at Houston. Over a 30-year career, she served 27 years with the Houston Police Department. She rose to the rank of the Assistant Chief, earned a master's degree in criminal justice. She was Chief of Detectives, Tactical Support Commander, and Director of Forensic Services. She oversaw some of HPD's highest profile cases, including serial homicides, corruption, domestic violence, sexual assaults, gangland slayings. We're so pleased to have her. She was recruited to the University of Texas and MD Anderson, and to head up their threat assessment unit. And she is a co-author with us on a new book, ebook that'll be coming out in the next month or two, that'll be given away free or just nominally. We want to make it available to everybody in Threat Safety Science, this new science of these threats, visible and invisible threats. One of the really important ones is patient suicide. So, Vicki, would you please take it away? And could you take us to 15 minutes after the hour, and that would allow us to have time for good dialogue and Q&A.
Absolutely. Thank you so much, Chuck. I appreciate it. Well, we're going to delve into what we call the death of despair. And having investigated these types of cases in the aftermath of a tragic event, I can tell you that it is a very traumatic event for not just the family who suffers the loss, but also for the faculty and staff who care to the care team for that individual. And so we're into prevention. And Chuck, I'm not seeing my slides move. There we go. Okay, now I have control. Thank you. So one of the things, I'm going the wrong way. Sorry about that. Excellent. Okay. So what we want to do is we want to take a few minutes here to explore some of the new Joint Commission standards that are going to become effective July 1st, 2019, and talk a little bit about these cases and some of the things that we can do to prevent these deaths from occurring in our hospital settings and also in the immediate aftercare of some of our patients. So when we start to look at the problem, we know that suicide is the 10th leading cause of death in the United States. And annually, we see more than 44,000, almost 45,000 Americans die by suicide. But the number of attempts completely eclipse that number, with 25 for every successful event. And so you put that on the time clock, 123 suicides per day. And the cost, I hate to put numbers on the death of an individual, but they're substantial. So one of the things you may see is from the National Institute of Mental Health, you may see these suicide profiles. And they talk about the propensity for men to die at 3 times more than women, and white males are more apt. But what that does is that gives us a false narrative in many cases when we look at the profiles. And during the Joint Commission Sentinel Event Alert from 2016, they addressed the 10th leading cause of death for individuals, but they wanted to stress that there's no typical suicide victim. And in my experiences, that is so true. We can't be lulled into a false sense of security with regard to who is vulnerable. But we can look at behaviors that are indicative of people who may be at a higher risk than others. Certainly, we recognize that people with mental and emotional disorders are 90% of the suicide victims. And many times, though, those mental and emotional disorders are not detected at the time of treatment. You may have people who present with non-behavioral issues who are at high risk for suicide. Also, so when we start to screen for these, when we start to do the medical history, when we start to delve into our patients, looking at previous suicide attempts, the risk of suicide 100% greater than the general rate for a prior suicide attempt. Knowing that helps you take the appropriate steps to prevent a vulnerable person from being exposed to an unnecessary risk. We look at history of trauma and loss. You may not have that in your clinical setting. You may not know that, or perhaps the family members can fill that piece in for you. Constant pain or illness, that chronic illness, a poor diagnosis, obviously drug and alcohol abuse, but when we start to see the social isolation, the antisocial behavior, the people who feel all alone and disconnected from the rest of the world are at a much higher risk than the general population. And then, of course, our high-risk population is extremely vulnerable after discharge. You see that particularly within the first weeks and months after discharge, the patients may have received the care but fall back into that hopelessness. So when we consider who's at risk for suicide, we want to make sure that access to lethal means coupled with suicidal thoughts, that we can take away one piece of that equation. And some of the literature has suggested that suicidal acts by in an inpatient setting is sometimes a very impulsive type of act. They may have decided to act upon suicide. They may have a plan for when they get out. But when the crisis period hits, when they're confronted with their disease and confronted with the other stressors that may contribute to that, they may be moved to action in the hospital setting. So the Joint Commission has provided some literature that is great for you to focus on, and I put this in here not to drill down on all the literature, but there's some important pieces about this that you may find helpful in providing executive leadership with input and to make your case to faculty. The Joint Commission received their data from a study that was conducted involving 27 states reporting to the National Violent Death Reporting System, and that is a voluntary or reporting system that's run at the federal level, and of course to the Joint Commission for accredited hospitals are to report. And the key takeaways here are that we have hanging, ligature deaths were the most common method of an inpatient death. And while the inpatient deaths and new studies, we can't be again lulled into that false sense of comfort that the studies coming out today are estimating that there are 48, 49, almost 50 to 65 deaths of inpatient suicides per year. And while that number may seem low, if you look at it and compare it against the same documented death rate for transfusion deaths, you're going to see a similar death rate. And we certainly are going to take all the precautions to protect our patients against those kinds of medical errors. We certainly want to make sure that we protect our patients against the risk to suicide. And when we start to drill down in these studies, we begin to learn that our ligature of risk are most commonly, as you would suspect, in private areas for our patients. 58% of those occur, almost 51%, in bathrooms. We have the 33% of them occur in a bedroom, 4% in a closet. They separated out showers with 3%, almost 4% occurring in showers, and with 7% occurring in other non-documented specific areas. So there are some extremely important points in terms of looking for your fixture points. When we start to drill down on these deaths and look at the reporting nature, we see that fixture points, door hinges, door over the tops of doors, door handles account for almost 54% of those deaths. And we want to consider how we can mitigate those risks for our high-risk patients. And what is a ligature risk? I mean, we can start to look at anything that can attach a cord, a rope, or other material, bed clothing, IV opportunities for attaching those to shower rails, beds, bed frames. There's been some success with over-the-door alarm systems that have been helpful for alerting our care teams to individuals who are attempting suicide. So when we start to drill down on the specific guidelines that are going to take effect on July 1st of this year, hospitals that are accredited through the Joint Commission are going to be asked to to take on this national patient safety goal. And they have 7 elements that they have asked the hospitals to try and drill down on to help identify these patients and mitigate the risk to those that are identified as being high-risk individuals. So not to belabor the points, I mean, the R3 report that was issued on November 27th and then just recently updated on May 6th provides the detail, the rationale, and the reasoning for taking on these mitigation factors. And so we're just going to quickly jump through them. I put them here in some detail so that you can look at them at your leisure. And obviously, the requirements for behavioral health care facilities are going to differ from accredited hospital programs. So, and within accredited hospitals, those that run psychiatric hospitals or psychiatric units in general hospitals are going to have to meet the same standards as behavioral health care facilities. So one of the things in the element of performance 1 that they point to is the environmental risk. Looking at target hardening, looking at making a safe environment for your patients, and removing those objects from the room that can be used for self-harm. They talk about a continuous monitoring in a safe location while patients are awaiting transfer. Recently in the Texas Medical Center, we had an at-risk patient who was suffering from behavioral health issues and was identified by his family and transported, and he was not continuously monitored and walked away from the facility and ultimately died before he could be found. So those kinds of tragic events occur. And so if we can work on our processes and procedures to protect our patients that have been deemed at risk, it goes a great deal towards prevention. The second requirement is that there be an environmental risk assessment. So non-psychiatric hospital units and general hospitals must implement procedures to mitigate the risk of suicide for patients at high risk of self-harm. They talk about one-to-one monitoring of these high-risk patients, removing those objects and assessing the objects brought in by visitors, and of course, utilizing the safe transportation procedures. One of the things that I've heard Chuck say on these webinars many times are talking about checklists. And checklists are so vitally important because we get busy, we start working, and we get distracted by other in-the-moment events. So if we have a checklist for our staff, that if we have an at-risk patient that's identified through our screening processes, who can go into our clinical settings and begin to remove those items that may pose a risk of self-harm so that the opportunity for self-harm is reduced. So when we start to look at the recommendations from the American Society for Healthcare Engineering, there's a 3-step process. You have to identify the acute care or emergency departments and identify those patients at risk for intentional harm to self or others. You need to observe those patients. You have to have a one-for-one monitoring system. And there are some companies that are coming out with these remote monitoring. Those sometimes can be defeated by our patients, and they are not recommended. It is currently the recommendation that there still be the one-to-one monitoring of these high-risk patients. And then number 3 is to remove. You want to monitoring with continuous observation is not feasible. You must remove clinically, mitigate all the environmental safety risks. And so you've got to have this 3-step process so that you can eliminate the risk to our patients. So when we look at the second requirement, they talk about screening all individuals served in the behavioral health care setting for suicidal ideation using a validated screening tool. We want to screen all patients in the general hospital setting who are being treated or evaluated for a behavioral health condition. if that's their primary reason for being there, it's got to be part of our process to screen these patients. And the screening tool you want to use is a validated screening tool. I've got an example over here to the left that's offered by the Zero Suicide Initiative. And those are step-by-step processes that you can investigate. The Zero Suicide Institute is referenced by the Joint Commission as a viable resource to our patient health care and to look through and to provide you with those step-by-step processes to help. There's the Pocket Safety Assessment Guide. Use evidence-based processes for a suicidal risk assessment. One of the things that you have to do is once they have been screened and you have a positive indicator for suicide risk, you need to drill down. You need to have a more robust tool, and there's several here listed. The Columbia Suicide Severity Rating Scale is one that's advocated and as a resource by the Joint Commission. These tools, you need to take and document the level of risk that the tools show you, the low, the moderate, the high, and take the appropriate commensurate steps to protect your patient. You also need to have those written policies and procedures. You must codify this for your staff. You must hold them accountable for following the written policies and procedures to addressing those individuals who you're serving, or those in a general hospital facility as identified as a risk for suicide. So at a minimum, you want to train and have competency assessments for your staff. And we often talk about not only competency, but currency. We want to make sure that our staff who've been trained and deemed competent in the past remain current on the appropriate protocols, processes, and procedures. And so that means that you need to have guidelines for reassessment, and you need to reassessment of your patients. You need to have processes for monitoring those patients who are at high risk for suicide. The next performance is that you need to have policies for counseling and follow-up at discharge with our patients. One of the things that has been proven to be one of the most successful, the VA has an extremely successful program that they've implemented for follow-up with their high-risk patients. Once they have been stabilized, they've reached that baseline level, post-discharge, they recognized a problem. There was a study that was done in they examined suicides, post-discharge suicides between 2002 and 2015, and they found within 7 days of discharge, they had 141 reports of suicide, and that compared to 29 inpatient suicides during a longer period of 2000 to 2015. So they were looking for a mechanism to and opportunities to counter that negative aspect of the aftercare for the patients. And what they found, and this became part of the follow-up process for the VA, is that if they had a safety planning and intervention plan that was instituted, and that was coupled with a few supportive monitoring phone calls, it reduced subsequent suicidal behavior by almost half. Now, that's a significant finding. That outreach, that human touch, that making sure that once they are discharged from the hospital, they have not been forgotten. It's an effective intervention tool. These phone calls can be brief, and they do not require advanced credentials to carry out. The VA has a program where they call Vets Caring for Vets, where vets would make those follow-up phone calls just to check on the guys, just to make that camaraderie, and there was a connection and there was a link, and the reduction in post-discharge suicides was significant. So when we talk about monitoring, and this is something that is so tragic when we come in and have to investigate an event after it has occurred. One of the things, the records begin to pull, and we begin to see that in cases where there has been an inpatient suicide, that the monitoring of that high-risk patient was not being properly documented. There were not proper processes and procedures and protocols that were put in place to make sure that that was a priority. So when we talk about the performance factor number 7, monitor and implement effective policies and procedures. Can't stress this enough. Monitoring adherence is essential, especially in those cases where a high-risk person has been identified, and that one-to-one monitoring just cannot be overstated in those cases. I know we all get busy. I know there's a lot of things going on, especially in our emergency departments. And that outreach, that moment, that is your opportunity to save a life. And so I know we've rushed through a lot of this. There's so much information to push through, but I wanted to point you again to the Zero Suicide research. It's a foundational belief that suicide deaths are preventable deaths. And there are some steps that every hospital can adhere to. You have to lead. You have to lead from the front. The leadership has to be engaged. They have to be committed to reducing these inpatient suicides. You can do that through some of the target hardening steps. You can do that through education, processes, checklists, screening, but most importantly by follow-up. And we talk about the 7 steps that are offered by the Zero Suicide Initiative: to lead, be a leader, to train your staff, have a competent, caring workforce that are not overtaxed, that can, when one of these cases come in, can give them the time and attention that they need, because they truly are in that moment saving a life. Identify those individuals with a suicide risk using a comprehensive screening assessment tool. You can start out with the high-level screenings and then drill down into some of the more comprehensive tools. Engage. Everyone who is identified at risk of suicide has to have a care management plan. That cannot be overstated. Sometimes when you make outreach to these individuals, we had a case where I was actually called in and talked to an individual who was driving around with a gun to his head. And when we talked him in, the job was not done when we brought him in to the hospital and we got him there. The job of talking him down continued after he was safe and in custody and had surrendered his weapon. And now we start to talk to him about how the suicidal ideation that he was experiencing could be transitory, that there are treatments, successful treatments. There have been successful individuals who have been in that same level of abyss, and that they have gone on, once they've gotten treatment, once they have gotten the help that they need and the support that they need, have gone on to be successful. And that this is a critical event in their life, but it doesn't have to be a tragic event in their life. And that there is hope, and there are resources available for them to go on and have a pathway to success, building that forward. You're going to treat the suicidal thoughts and behaviors using evidence-based treatments. You're going to transition individuals safely with warm handoffs, the supportive contacts, and you must improve your policies and procedures through continuous quality improvement. Develop that culture of competence and Chuck has talked about calling safeties on yourself. If there's a step you've missed, something you could have done better, as a leader, be the first one to step forward and say, hey, I could have done this better. I really should have done X, Y, or Z. Not in the post investigation after a tragic event, but more importantly, to do that in every case study. When someone leaves your care, that transition has been successfully made, to go back and look at your policies and procedures, to look at how you handled that patient, for that continuous quality improvement. And that's how we get better. That's how we engage our staff. That's how people know it's okay not to be perfect, but it's not okay not to improve. And that's what we're looking for. I know we rushed through that very quickly. There's a lot of information, and I hope I didn't speak too quickly for you. There are many, many case studies to illustrate this, but I wanted to get the information out to you about what the Joint Commission standards are changing to become and how important they are to implement in your organization so that we can get to that zero suicide. So, Chuck?
Well, thank you so much. I really appreciate it. You've done a great job, Vicki. This is very, very important information, and I know that our audiences have asked for a lot more information on workplace violence. So perhaps when you do that next presentation, you could give us an update on suicide, because I think this is going to be very well received. I'm going to ask Kyle Kemp, our Chief of Staff, now to activate our survey so that we could just ask a few more questions here, and that is, and survey you regarding drug diversion. If you'd like to have another webinar with more case studies and more drill down, please give us that indication with the survey. And then specific areas or case studies that you have not seen yet, please include those in the drug diversion topics if there's more information that you'd like to have. Next month, we have Dr. Jean Huddleston from the Mayo Clinic, who's leading the global initiative on mortality reviews, and found that 80% of the errors contributing to, or issues that contributed to deaths at the Mayo Clinic were errors of omission. So if you'd like another one on that, let us know. And more specifically on the errors of omission topics, the things that we don't do that we need to do. We'd like to know more about that. We're also going to be heading in this summer to have another drill down on patient safety issues relating to emergency department safety and misdiagnoses. And we'd like to know if you want to give us topics that you'd like to have us cover. If you want us to move that up in the lineup, please give that a high rank or a high rating. And the topics that you'd like to have from the emergency department. So what I'd like to do is go first to Kim and ask if there's any more you'd like to cover, and then react to Vicki. And then, Vicki, any topics on diversion, and then we'll go to Dan for his reactions to both. So, Kim, your comments on what you just heard Vicki present.
That was amazing information and obviously very timely. I think a lot of the principles that she talked about apply across the board, and I thought it was a great presentation.
Fantastic. And Vicki, you didn't get the chance because we went right into the suicide topic. I know that drug diversion is also in your basket of things that you have to address at Anderson. Are there questions or topics that you think are important for us to discuss now and then maybe in the future?
I think exploring the topic of that peer pressure and the bullying in the workplace so that the shortcuts are taken is a topic that's very important, because we see it more and more, and when processes and procedures aren't followed, then employees become vulnerable, and when we have to do the investigative part, it's a tragic event for everyone on the care team who says, I trusted that person. And so talking about ways that we can deal with the bullying, I think, would be very helpful.
Great, and I'm going to come back to both of you regarding what were the new things we're seeing. Dan, would you like to react to both or either Kim's presentation or Vicki's?
I would. I sat here with a hollow feeling in the pit of my stomach as I listened to both presentations, because much of it hits home. And broadly, because this is such an important subject. And you just hit all of the key points and all of the alerts that people ought to be looking for. 3 observations and then a couple questions. One is, if you see something, say something, ought to be a principle that applies here as well. Secondly, transparency is good business in all of this. Thirdly, to involve patient, family, and the victim representatives on your task forces, committees, and work groups if you're not doing it already. A question for Kim and then one for Vicki. Kim, I'm going to ask, this got two parts, and I think I'm asking the same questions in two different ways. The first one is, can electronic health records such as Epic be foolproof so that footprints are left, and I don't know the electronic term for that, that are left whenever somebody goes in and changes something? Let me say it a different way. One of my sons does marathons, triathlons, Ironmans, etc., and he wears a chip. Anytime he crosses a transition point, just like every competitor does, it registers where he was and what the time was. And I'm wondering, and I may be way behind the times in asking this question, it's kind of maybe a dumb question, but cannot we, in that case, they're tracking a body, a live body running, or swimming or biking, I just wondered if we can't track every single opioid, every single drug in the very same way. Let me ask the question of Vicki too now, and Chuck, you can move it on to how you handle the answer, how you do that. Vicki, I couldn't help but think about the transition from patients as they go home and what the risk is of mental health issues, whether more patients die from suicide in the hospital or after they go home. My question goes into the root cause analysis subject area, and that is, and by the way, I'm a veteran as well, and I'm kind of wiggling in locally here in Grand Rapids, Michigan, to be somewhat of an advocate on behalf of veterans here in the private sector. But I'm wondering if as regards to the RCA, if a patient has been in the hospital, commits suicide after he or she goes home, is there a tail that can draw the patient back, subject matter and the reason for the death and what could have prevented it back into a hospital RCA? I'm guessing not. I'm guessing liability gets in the way from even talking about that. It seems to be a worthy subject. So that's the second question, Vicki, and both of you, if you've got responses to either one.
Well, Dan,
the
Joint Commission tracked patient suicides 72 hours after discharge. Police departments, obviously, when they get into the suicide investigation, want to know from the family if someone has been recently treated for mental health issues, and they frequently go back to the hospitals and get the medical records. But there's not a really good system for tracking those. And what we like to do is to investigate anytime one of our patients, and cancer patients sometimes get extremely bad news. They have to deal with a great deal of pain. When we have one of our patients commit suicide, we want to get to that root cause. We want to see, is there something we could have done better? And so we go and help gather that information for our organization, and it becomes part of the case study, the case file, so that we can get better at what we do and meet our patients' needs in the most compassionate and effective way possible.
Okay, thank you. Kim?
Yeah, and to answer your question, so I guess you had a two-part question. I kind of had a two-part answer. It's interesting that you brought up Epic and the EHR and being able to kind of see absolutely everything that's happened there if something's changed. That's something that is actually a rather advanced diversion investigation tool, and that is one of the things that I look at when I'm doing auditing is I look at when an entry was made. So for instance, these records do track that. So I'm able to go in and see if Sue gave, morphine to a patient, I can tell if she recorded what the patient's response was. So I can see if she goes and gives it and then immediately says that the patient had excellent relief. And that's a that's a clue that diversion may be happening when the individual has no intention of ever giving it to the patient, so they just go ahead at the front end and record their relief or their post-medication pain score. So those types of tracking devices do help us quite a bit in diversion investigations. And then I think the second part, tracking somebody and where they are, there are systems that are not meant to track for diversion, but I've used them actually, systems that track staff throughout a unit during the course of a day and they produce a report. And so I've actually been able to use those before. Again, they're not designed for diversion, but I've been able to use those to show that an individual pulled a medication. They said they gave it to the patient, but they weren't near that patient's room for a period of like 4 hours. The other thing is with scanning technology, bedside scanning, you would think that would help too, because that the nurse would have to go into the patient's room, scan the medication, scan the patient's armband, and that would make it a little bit more likely that the patient got it. Unfortunately, we see people producing duplicate armbands for patients. We see people keeping empty packaging or even old syringes and scanning those, and then scanning, the duplicate armband and never going anywhere near a patient room. So there are some tracking devices, and they can be very, very helpful. Unfortunately, I think people who are really savvy find ways around them.
I understand. And on both of these, I just want to put a plug in for inviting the patient family to participate in root cause analysis as relates to both these subjects.
And
I couldn't agree more.
Dan has been such a national champion on that issue, and thank you for that, Dan. So, Kim, one of the topics that we rushed through during our news was on slide 16, which addressed this stimulant, the number of deaths from stimulants now, and the cocaine with and without synthetic opioids. In prior webinars, we talked about the first wave was this aggressive number of prescriptions and huge number of prescriptions for opioids, and then the second wave was when that was kind of reined in, then people moved to heroin, and then the third wave is the fentanyl. Can you address, are the stimulants also and the mixes with stimulants becoming a problem in hospitals the way they are out in the illicit world?
Yes, they actually are, and we have. I've seen a few cases. I've investigated a few cases in my past over the years that the primary drug that was being diverted was a stimulant, and those were kind of few and far between. Usually people prefer an opioid, but we have seen a very substantial increase in the cases involving diversion of stimulants. So I think we're seeing it as well in the hospital environment.
And then my second question is really for both you and Vicki, because, when you look at where MD Anderson is, there are 160,000 caregivers and students almost within walking distance. A number of the hospitals are more outlying, but an enormous number of people with multiple employers. When someone is caught diverting drugs, it's kind of a two-part question. One is, what about when they resign or leave one place, or they're asked to leave and maybe nothing is done formally, then they just bounce over to another facility nearby? Is there any way to prevent that? And then the second thing, and Vicki, kind of where I'm heading, what about when you have the 2 or 3 people working together, be it a physician that's getting something from caregivers, or kind of a ring of 2 or 3 people that are involved in diversion? So the two questions are, one, is there any sort of database, or is there any way that people are kind of tracking to make sure that those abusers in one place don't just show up at the next hospital and then have a problem? And the second is this team approach. Yeah, Kim, you want to take it first?
Sure, I'll answer the first part of that. The way that the best effort we can make to stop itinerant diverters is to report robustly. And that includes to any kind of professional board, but diverters don't always have a professional board. So that also means reporting to law enforcement. You're much more likely to have a record there than sometimes even a professional board, or you may have a record that would be discoverable by a future employer, but it may take a really long time with a professional board because there's obviously an investigation that has to happen, and many boards are quite overburdened. So I think, robust reporting is really the key. Because of due process considerations, there really isn't a database that you can necessarily go to. Diversion events certainly could be reported to the National Practitioner Database, but I don't think that they commonly are.
Right, that's my understanding. Vicki, do you want to tackle that? I know that there have been multiple medical centers where there's kind of a team approach, or there are multiple people involved, and when investigations are done, it's not the isolated diverter.
Right. Those criminal conspiracies that are put together, when you start to do your background checks on individuals, and I can't stress that enough, when you're into the hiring process, being able to look back at the employment history of the person. We see a lot of the team approaches with regard to what we call our gypsy caregivers, the ones who hop from hospital to hospital to hospital, and who have a tendency to travel in teams, or you start to see linkages between individuals who may have a criminal history associated with past performance. And we in law enforcement have the ability to go in and look at not just conviction records, but also arrest records. When you start to see problematic behavior, DWIs and other things, you might want to have a process at your hospital on the background check, on the onboarding process, to drill down a little bit further and to check out these associations. I tell you, the patterns that were discussed by Kim New are things that you see replicated over and over and over again. And the more we have education, such as these webinars, to push that information forward, to see how clever these individuals are and what the common diversion techniques are that are utilized, and you begin to see those patterns and behaviors and incorporate those in your screening processes for who you bring into your institution, who you employ, are some of the best methods for preventing these types of events and identifying high-risk individuals.
Well, great. And so we want to finish on time. We're so thankful for two terrific presentations. Thank you both. You just did a great job. Lots of great and really, really actionable information. So God bless you. Thank you so much. Dan, would you please close us? And then we'll see everybody in June with Dr. Huddleston. And if the speakers could stay on just for a minute so we do a quick process improvement loop, see what we could have done better for you. Dan, would you please close us?
I will. I want to thank everybody, each and everybody on this call, this webinar, for participating. In one way or another, you may have asked some questions or had questions to ask, and we'll follow up. And I pray that each of you leaves this meeting with ideas on how you deal with either one or both of these subjects. I'll also pray for those on this call who may have current experience with one or both of these subjects and may need help of some sort, and that happens. God bless each one of you. Thank you.
Thank you. And just one last note. We have some documents that have been published by Kim. We had one question there. And we also offer continuing education credits for nurses. So we just wanted to make sure people knew that. Thank you so much. And we'll see you in June.